I'm speaking with Dr. Tom Nowicki, Assistant Professor of Emergency Medicine and Associate Director of the Integrated Residency Program in Emergency Medicine at the University of Connecticut. Good morning.
Good morning.
Thanks for being here.
Thanks for having me.
Could you tell us how you assess in the first few seconds who is most acutely or severely ill and needs first and most attention?
That's a skill that comes with time and practice. However, there are a few clues that you can pick up early on in your training. I think vital signs are of extreme importance, both vital signs in the field that the paramedics will bring you, as well as your initial set of vital signs. You can then tell if the patient is in shock, at least hemodynamic or hemorrhagic shock, as opposed to the other forms of shock. The information that you get from EMS about the severity of the incident is very important. History, again, as in most examinations, is very key. When assessing the patient after the initial set of vital signs, assuming that they're not in hemorrhagic shock, there may be other forms of shock as well as the general appearance of the patient. An awake, alert patient that follows commands and is able to provide history is a good sign. Some injuries may be difficult to assess at first and may be rapidly progressive, such as blood loss into the chest, abdomen, or external bleeding.
I'd love to see your exam of the injured patient. Can you tell me about it?
Sure. What I'd like to do is actually give you a demonstration here. This will be a brief overview of a general evaluation for a blunt trauma patient.
Thanks so much.
You're welcome.
EMS, we have a 22-year-old male involved in a motor vehicle accident. The patient was an unrestrained driver. He is alert and oriented ×2, pulse 108 and regular, blood pressure 110 on 55, respiration is 28. Patient is currently stable, ETA 3 minutes.
Okay. In evaluating the trauma patient, it's important to have a well-equipped room, know where all of your equipment is and how it works. It's also very important to follow universal precautions, protecting yourself and your staff as well as the patient. For the purposes of this demonstration, I'll remain in my current attire. However, typically I would have a gown, mask, goggles, gloves, etc., possibly even booties. So the first step is to start with the airway, breathing, and circulation, also known as the ABCs. The first step, the airway, you can tell by the general appearance of the patient if he appears to be breathing well and on his own. You'll check the airway for patency. Sir, can you open your mouth for me? I see no obvious obstruction of the airway and he appears to be breathing well on his own. Step 2 is the breathing. Initially the patient is robed in this case. Typically I would have several people around helping to disrobe the patient, which we will do in a moment, but I'd like to get a quick assessment just to hear the breath sounds at this point. Can you take a big breath for me? One more. Good. You can breathe normally. The breath sounds are equal on both sides. I hear no crackles or wheezes, and he appears to be moving air well. His chest is rising symmetrically in addition. The circulation is the third of the ABCs. This is obtained by general appearance. If the patient has pale skin, he may have lost a significant amount of blood, as well as cyanosis. Pulses should be examined, both sides, both upper and lower. Evaluating the circulation should include the patient being placed on cardiac monitor, blood pressure cuff, and an initial set of vital signs. This is very important in helping to determine the stability of the patient initially. The next step should be a very quick neurologic assessment, sometimes referred to as D or disability in the ABCs. This could include the Glasgow Coma Scale if you suspect head injury, but in general you want to get a sense of the patient. Sir, do you know where you're at right now?
Yes.
Where are you at?
I'm at the Yukon Health Center.
Do you remember what happened to you?
I was in an accident.
Good. You're going to be okay here. There are a lot of things happening to you all at once, and we're going to be cutting off your clothes and examining your entire body. So I want you to try to relax and just help us as much as you can, okay?
Okay.
The initial portion of the GCS is the examination of the eyes. This patient has spontaneous eye opening, which will give him a score of 4. The next is verbal. The patient is oriented and makes sense. This will give him a score of 5 for verbal. Sir, can you move your arms and legs for me? Good. Can you squeeze my hand here and here? Good. The patient's motor score is 6 because he is able to move and follow commands. The next step is often referred to as E, or exposure of the patient. At this point, we may have several people helping to expose the patient by actually cutting off the clothing. The patient is strapped to the board as well, and in order to get a full examination of the patient, we may want to remove these straps at this point. As we continue to expose the patient, it is again helpful to have several people helping so that you can continue back with your exam. Certain things may be different depending on the type of trauma. Blunt trauma, as in this case with a motor vehicle accident, versus a penetrating. If it was a gunshot wound or a stab wound, we would want to remove every single thing that is on the patient's skin, even including cardiac monitors, to look for any sign of a bullet wound or knife wound beneath. So as I move back to the head of the patient, the first thing that I'd like to do is anteriorly assess to see if there's any facial trauma or head scalp injury. I feel no lacerations. I have no evidence of bleeding. I can move and onto the eye exam to make sure that the extraocular muscles are intact. I can check pupillary response. In addition, I'd like to look in the ears. Any sign of a basilar skull fracture may be revealed by looking for blood behind the eardrum. The eardrums are clear, and the rest of the head exam appears to be intact. In a head-to-toe stepwise fashion, we'd like to move down and see the neck. Sir, I'd like you to hold your head still. I'm going to examine your neck here. Try not to move. Palpation of the cervical spine should follow, feeling for step-off or any bony tenderness. Does this hurt you, sir?
No.
Try to remember to ask the patient to only say yes or no, not to shake the head. Sir, can you open your mouth? Open wide, looking for false teeth or any other foreign body that may make later intubation more difficult. At this point, you can get a quick assessment for jugular venous distension as well. This may be evidence of a cardiac tamponade or elevated central venous pressure. Moving back down to the chest, at this point it is wise to re-examine the lungs now that the patient's been disrobed. Can you take another big breath for me, sir? Good. And one more. Also assessing the cardiac examination. To listen for murmurs, distant heart sounds, which may be evidence of cardiac trauma in specific. While doing this, I feel no air or bony crepitus. Does this hurt you, sir?
No.
You may also occasionally find a flail segment, which is a mobile portion of the chest. Next, I'd like to move to the abdomen. As opposed to the typical abdominal examination, in trauma, we'd like to start with inspection as you move down, chest, abdomen, thorax, head, and extremities, looking for any external signs of trauma. We may move right into palpation as opposed to auscultating the abdomen in this situation. Again, trying to get a quick assessment for any hidden injuries. There are very few places that a patient can hide blood. The chest, abdomen, thighs, or external loss of blood may be significant. So the abdomen in this case appears to be flat, not distended. I see no external signs of trauma. I'd like to palpate all 4 quadrants. Does this hurt you, sir?
No.
The abdomen appears to be intact. The next step would be to assess the pelvis, both by putting pressure to assess for open book pelvic fracture, which may be very unstable, and again, another site of significant blood loss. Does this hurt you, sir?
No.
The pelvis appears to be stable. Next, I'd like to move on to the extremities before we roll the patient, at which time we would examine the back. Does your leg or arm hurt you, sir?
No.
In general, I see no external signs of trauma. I'd like to both palpate all of the bones as well as assess the joints. The hip, knee, and ankle appear to be non-tender, as well as the toes and rest of the foot. No deformity. Reassessing pulses at this point is again important. It's important to disrobe the patient to reveal all of the areas which you'd like to examine. In this case, I will assess both pulses at the same time. In an impaired patient, it may be very difficult to tell if there's an injury. You'd like to know about every injury on your first pass, or potential injury, in case you require X-ray or other diagnostic modality. Any pain there, sir?
No.
Okay. What we're going to do now is turn you onto your side so I can examine your back, okay?
Okay.
What I'd like you to do is just relax with your arms right on your belly for me. And I want you to just let us turn you onto the side. Don't try to help us, okay? In rolling the trauma patient, the idea is to have as much help as possible. I'd like to have one person at the head responsible for maintaining the position of the head when the patient is turned onto the side. There should be no traction or pulling. That's a misnomer. It's purely stabilization or holding the head. Then to have two people help hold one shoulder and hip, the other leg and abdomen.
1, 2, 3.
At this point, I'd like to go ahead and remove or tuck all of the clothing so that it can be pulled from the other side, as well as removing the board. I will now examine the back of the patient. Sir, I'd like you to tell me if it hurts along any of these bones here. Again, feeling for step-off or any bony tenderness. While doing this, I'm also examining the skin of the back to see if there are any signs of external trauma. Feeling for air or bony crepitus of the back. At this point, typically we would also continue on with a rectal examination, and the male patient assessing the position of the prostate prior to insertion of a Foley catheter, as well as the neurologic tone of the sphincter. We can now roll the patient back on your 3.
Okay, back on 3. 1, 2, 3.
At this point, it may be necessary to roll the patient to the other side in order to move the clothing. Sometimes, if the clothing is pushed well to the side, you can remove it in that fashion. In general, this patient appears to be stable. He is awake, alert, following commands, and there is no evidence of any external trauma. And at this point, again, if there are any concerns, you should go back to the ABCs and start from the beginning.